And welcome to the Encephalitis Podcast. My name is Prav and I'm from Encephalitis International. Today we'll be asking the question, what's new in autoimmune encephalitis? To find out more, I am grateful and thrilled to be joined by Professor Sarosh Irani. Professor Irani is Professor of Neurology and Neurosciences at the Mayo Clinic, Florida, former Professor of Autoimmune Neurology at the University of Oxford, and Adjunct Professor at the University of Southern Denmark. He was part of the team that discovered LGI1 and CASPR2 antibodies and has cared for many patients with LGI1, CASPR2, NMDA, and other forms of autoimmune encephalitis. Professor Irani is one of the world's most experienced clinicians in this area and has published over 200 scientific papers about autoimmune neurological diseases. He is also a member of Encephalitis International's scientific advisory panel, providing expert professional guidance which informs our research strategy, information resources, and guidance. Thank you for joining us, Professor Irani. Welcome to the podcast.
Thanks very much for the invite. Happy to be here.
Great. So starting from the beginning, could you explain what autoimmune encephalitis is?
Yeah, sure. That's always a bit of a challenge as things change and diseases get reclassified or better classified. But um, I often think we should still consider this as swelling of the brain with a primary autoimmune etiology or causation, put simply. And often that means having an antibody around. Often that means having an antibody or a set of um, immune cells, which typically we can't measure in clinical practice, that are causing the disease in the brain. So I guess that's the bit that we can't necessarily see, but we infer from the clinical syndrome.
So there are lots of different antibodies, LGI1, NMDA, CASPR2, for example. How are these different?
I mean, it's a very good question, and the way you put it is kind of nicely leading because I often think, and I've really grown to believe this stronger and more clearly as time's gone on, that these are very different syndromes to one another. And we put them under this umbrella of autoimmune encephalitis. But if you're a 5-year-old girl who developed psychiatric problems and a seizure, you are over a few days and became very, very unwell within a week and was on intensive care and had NMDA receptor antibodies. You are very, very different to a 60-year-old male who developed seizures over several months. And when they went to see the first doctor, they said, not sure what this is. And the second doctor said, not sure what this is. And the third said, oh, this might be worth you seeing a neurologist. And the fourth said, oh, actually, this is LGI1 antibody encephalitis. So I think the way you put it is really good because I see these as discrete individual syndromes. Yes, they have some overlaps, but they have such differences between them that I think we should begin to think of them as independent syndromes to one another.
Right. And so I think that leads me on nicely to the next question, which is what is our history of understanding autoimmune encephalitis and how has that evolved?
Yeah, it's a very good point. I think we have got to the point where um, if we wind back, say, um, I'm trying to work out the year now. If we wind back, say, 20 years, people knew about maybe one or two antibodies, um, and it's not clear that those were necessarily the antibodies we even measure today in clinical practice. So, to think that this field 20 years ago was basically absent, and now we have 80 antibodies around, many antibodies around, I shouldn't cite a number, that are either very well proven or proposed that associate with these diseases. And each of them pulls out a relatively distinctive syndrome. Certainly, if you pick the top 10 antibodies, they pull out very distinctive syndromes to one another. Then the field's evolved in a way that we are getting so many more diagnoses. We're understanding so many more conditions that were previously poorly understood. It's been super exciting. And if you think, okay, so we're motor neuron disease, stroke, multiple sclerosis, these diseases, dementias have been known about for 200 years, and people still haven't unlocked secrets of them properly. Um, we're very lucky to be in a field where we're beginning to really get down to what are the main clinical clues here? What's the molecular pathways that underlie these diseases, and how can we impact treatments? And we're getting there quickly, I think, compared to some of these other diseases. So it's a very, very exciting time, and I think the evolution has been really, really dramatic. The one thing I would say is, of course, as these diseases evolve and we find nuances with each one, we need to be very careful about correctly diagnosing patients. And I think misdiagnosis of patients remains a big issue that we need to address as a field.
That's yeah, it's an interesting point about misdiagnosis, and a lot of conditions are mistakenly diagnosed as autoimmune encephalitis. Could you talk through what some of these are and why they are sometimes misdiagnosed?
Right, sure, yeah. So most cases with autoimmune encephalitis come on quickly. Most cases come on a few days to a few weeks. I think there are some cases certainly who we and others have seen and who have been well reported in the literature that come on over months or years. Um, but of course, then that brings into play a huge variety of illnesses which come on over months or years, and that's one of the reasons that autoimmune encephalitis is often, I would say, overdiagnosed. Of course, please don't forget that underdiagnosis still remains a problem. Lack of recognition is still a major problem, as Encephalitis International have shown in surveys before. But, I think right now we're dealing with this epidemic of misdiagnosis, which is overdiagnosis. And I think duration is one of the reasons. People are allowing anything in that has a long duration now. Um, I think a lack of clear understanding of the precise phenotype is another reason. Um, so, not being precise with exactly what this disease is and exactly which patients do not have this disease. I think the other reason is people prefer to give the diagnosis of autoimmune encephalitis because it means you can reach for steroids and potentially treat someone. We all want to treat our patients, of course we do. It's one of the reasons I came into this field is because it's very gratifying treating patients who then improve. But you can't overdiagnose on the basis that you're going to get a potential response to steroids. And I think that's the other issue here. And we have patients who have um, dementia syndromes, who have mood disorders, who have functional disorders, who all get bucketed into, is this autoimmune encephalitis? I think the other thing that's begun to emerge is there are symptoms in patients with absolutely classical forms of autoimmune encephalitis, including um, pain, neuropathic pain, including fatigue, that overlaps so broadly across almost any disease that there's sort of a conflation with other illnesses then. But these features happen in people who have a classical autoimmune encephalitis with highly typical distinctive features, not just anybody who has some brain fog or some difficulties with thinking, right? And so I think being super specific about your illness definition is really, really vital on a clinical basis. Finally, the other thing I think is that too many people get diagnosed with a normal MRI and a normal spinal fluid examination and a normal EEG. Now, if you have normal in two of those three, you should really start questioning the diagnosis. If you have normal in one of them, you should really start questioning the diagnosis. And I think that perhaps doesn't happen enough. And people want to treat their patients. They think of the diagnosis early. I often call it a not to miss condition because, it is a medical emergency. You don't want to miss people who can respond to immunotherapy early. And on that basis, I feel like it's overdiagnosed, and that has become a problem worldwide.
Something you've mentioned is treatments, and I was wondering how the landscape of treatments for autoimmune encephalitis has evolved over the last few years.
Yeah, I guess we're still reliant on clinical observational research, and that's not to be undermined at all. People would say, well, we need randomized trials. I'm not so sure we do. I'm not so sure we need randomized trials in a disease where, companies will spend 100 million, 200 million in a randomized trial. You get an answer out that is a very specific group of patients treated by a very specific drug at a very specific time in a very specific way. Does it really generalize to all patients that we then see? I'm not sure. We would need to do a multitude of trials along the way that then change the timing, change the drug dose potentially, change the way you administer it, change how early you administer it. And that's never going to happen in this field. It's already proving challenging to recruit patients for these trials. So the landscape of treatment, I think we must acknowledge, is going to be reliant on expert observations. And I think expert observations are pretty good in these diseases. We have a lot of concordance between experts when we go to meetings and when we talk about these kinds of things. There is broad concordance. And we've learned about the use of steroids and the use of plasma exchange. We've started to learn about value of rituximab in treating these patients. And while we're all very welcoming of new therapies, I think there just needs to be a little skepticism about how translatable clinical trials will be to these populations. Nevertheless, there are clinical trials undergoing, and that's great news for the field. And they will hopefully give us some of these answers with some new drugs. I think it will be very exciting to see how that evolves in the next few years.
Absolutely. One of the other questions I had was that there seems to be growing evidence of a genetic predisposition for autoimmune encephalitis. And I was wondering if you could talk a little bit about this and what the implications are of this.
Yeah, sure. So, Prav, when my patients ask me that question, I always say to them, please don't think that this is an inherited disease. That's the first thing I always get across because of course they're concerned that their kids will suffer from this. But if you ask them, did your parents have this? They'll say no, right? It's extremely rare that there is an inherited case. I've never seen one myself. There are a few reported in the literature, but it's very rare. So it's not that this is inherited, but it's almost like a percentage of your predisposition to the condition may come from your genetics. So we know, for example, the best three examples are LGI1, CASPR2, and IGLON5, where there is a very strong HLA predisposition. So maybe up to 90% of those patients will have a specific HLA gene that they inherit. And that is a gene that shows self proteins to your immune system. That's the way it works. And so we know immediately that that's telling us that the immune system is carefully coordinating in health. And when you have this, it's one predisposition. But many of those genes that are present in 90% of our patients are present in 10 or 20% of healthy people. So it immediately tells you that gene is not enough to cause the disease. So there are there's lots of ongoing work trying to decipher whether there are other genetic predispositions, and we and others have found some now. There's some very exciting data from the NMDA patients coming through soon, which shows again there's a genetic predisposition, but again, we don't see that disease running in families. So it's like the genes are giving you a little piece of the puzzle, but by no means 100% of your predisposition. And that's the way I try to explain it to my patients. So they understand that this is a really exciting area for research, and it may give us some amazing clues as to the biology of the disease. But it's not something which suddenly changes the fact that these diseases are essentially not inherited.
Yeah, part of the story, but not the whole picture. Yeah, thank
That's
you.
right.
And I do have a question from a member of our community, which is, what is known about autoimmune encephalitis that develops following viral encephalitis?
Yeah, it's a very good question. It's a very exciting area. So what we know best is there are a group of patients who develop herpes simplex encephalitis, who a few weeks later, as they're getting better from the herpes simplex, start to get worse. And at this point, they don't have evidence of the virus anymore in their spinal fluid. Instead, what's happened is they've switched from having a viral encephalitis now to having an autoimmune encephalitis. We don't quite know how this operates, but um, certainly there's lots of active research looking at that. And we're very interested in whether this works through the communications between the if you like the periphery and the central nervous system. So if this works so that the virus has to get out into your peripheral immune system, activate cells there, and then they make their way back into the brain. Um, and and that's probably the best example. And then, of course, when the second phase happens, you have to treat those patients with immunotherapy, not antiviral. So that's the really important clinical distinction. It's also possible that a few other viruses might do this, and there are viruses emerging. There's data emerging suggesting that that's exactly what's happening. So we're very interested in this. It's a hot space to watch. Of course, it makes you think maybe everyday autoimmune encephalitis was predisposed to by a virus that we don't know about yet. And that may be the case, but we haven't found that yet. Um, and so this is a field which will be hopefully, rapidly evolving in the next few months, and we will see whether we get increased knowledge and information that we can use to help our patients and treat them better.
Amazing. Yeah, looking forward to that. We have come towards the end of the podcast actually. We've tried to discuss the kind of recent advances of autoimmune encephalitis. We talked about the genetic part of the story. We've talked about kind of mistakenly diagnosing autoimmune encephalitis and the landscape of treatments. I was wondering if there's anything else that we haven't discussed that you would like to mention before closing.
Um, I think there's two things that I think are worth mentioning. First of all, this disease is all about clinical recognition still. Yes, we send antibodies and everyone gets excited about antibodies, but they have a rate that comes back as what we call false positives. So they're not necessarily the right antibody in the right patient. And the more samples you test, the more false positive results you will get. So this set of diseases comes back to careful clinical observations plus very careful lab studies in conjunction. So I just want to highlight that, I think it's really important we go back to the basics. We go back to medical school 101 as physicians treating these patients, and we're trying to work out what are the precise features that patients have that make us think of these diseases and that should make us think of these diseases and should not make us think of other diseases. And I still think those sorts of studies, detailed um, phenotyping of patients is very valuable. Um, we don't yet know if we then diagnose a patient what the full extent of the tests we should be looking at is. So we and others have shown that spinal fluid may show some very exciting hidden surprises, and I think we should be doing spinal fluids on every single patient with encephalitis or presumed encephalitis. It's massively overplayed as a concerning test, to do it's horribly named, right? It's called a lumbar puncture. I mean, who would name that? Who would give it that name again today? It's a very simple test when done in specialist hands. We do hundreds a month. When I was a junior doctor, I think I clocked up 600 in my neurology time or something crazy like that. These are very quick. You can do them in 5 minutes. Patients have some discomfort, but not, this is not something which should um, give patients significant complications or concerns if done properly. And we should be doing these to everyone. The spinal fluid holds hidden secrets that we otherwise completely miss with our patients. Um, the other thing that I would say is that we don't yet know quite so well how we capture the best measures of how patients have done, their outcomes. So um, I feel like we should get better and better at doing that. And we should understand more and more that the current measures we're using, an MMSE, even a neuropsychological examination, certainly some of the clinician rated scales are terrible. And we should not be relying on those. We should be looking for new outcome measures to improve the patient's long term uh, trajectory by basically capturing the things that matter to them and their relatives. And I think these so-called patient-reported outcome measures, we and others are going to hopefully be able to show that they mean much more to patients than the current measures. So I think lots to do. And finally, I also think that we don't understand the molecular biology of these diseases very well. yet. We're getting there, and lots of groups are making significant advances. But I think there's a whole area to be captured here. Understanding how the antibodies work, understanding how the T cells and B cells work. I think there's so much to be done that is directly therapeutically tractable for our patients that I certainly am super excited about research possibilities in the next few years.
Amazing. Yeah, so to sum up, yeah, the importance of lumbar punctures and getting that spinal fluid, the importance of patient-reported outcome measures, and yeah, looking forward to the promising advances in the molecular biology of autoimmune encephalitis. Yeah, so it's brilliant. Thank you so much, Professor. That was absolutely brilliant. And with that, we have come to the end of this podcast with Professor Irani. Thank you so much, Professor, for sharing your valuable time with us.
It's been great. Thank you for your time as well. See you soon, Prav.
See you. And I'd like to thank you, the audience, for listening and watching. We hope you have found this episode of the Encephalitis podcast helpful. If you have been affected by any of the issues raised, wherever you live in the world, please contact our support services. Encephalitis International is here to help in whatever way we can. For more information and our contact details, please visit our website, www.encephalitis.info. And together we can achieve our aim of ending death and disability from encephalitis. You can also find all the information you need in the podcast description. As always, if you can support our work, we would be extremely grateful. Please visit www.encephalitis.info/donate. Thank you again, and see you next time on the Encephalitis podcast.